You are live. Dr. Croissant's about to introduce us.
PK, how are you doing? We're just kind of changing the guard up here.
Yeah, that sounded like a great case that Dr. Sharma was doing. It's incredible.
Yes, I see you have Karthik and Vishal, so this must be a complex case.
Well, first of all, I want to thank yourself and, of course, Dr. Singh and the entire committee at ARCH for having us, again, do a live case for you. It's really a great honor for all of our team. And I want to introduce our team to you. As you know, this is to my left is the Associate Director of the Endovascular Program at Mount Sinai, Dr. Karthik Guja. To his left is Dr. Vishal Kapoor, who is the Director of Endovascular Intervention at Mount Sinai West, or Mount Sinai St. Luke's, right? I'm sorry, Mount Sinai St. Luke's. And to our right, we have one of our two endovascular fellows. This is Asma Khalik, who has been nice enough to spend 1 year with us. And outside, we have Sardar Farhan, who's also spending a year of endovascular work with us, which has been phenomenal. Our team in the room is, we have Fausto, our technician, Elizabeth, and we have, where's Damien?
Oh, Damien is outside.
Damien, okay. Damien went home. Okay, good. So we're all here and we're ready to go. So we have a great case to present. So I'm going to go ahead and have Asma go ahead and present the case.
Good afternoon, everybody. So next, please. So we have a case of a 58-year-old Hispanic male who has past medical history of hypertension, hyperlipidemia, diabetes type 2, EF of around 25%, known CAD, prior history of cabbage, moderate AS, and peripheral vascular disease, known peripheral vascular disease with prior interventions, and ESRD. So the whole gamut of predisposing factors. And he presented to our clinic with essentially CLI, worsening pain left greater than right, and he has a grade 2 ulcer of right basically at which has been there for several weeks, and it's non-healing, and he was referred to us by his podiatrist for that. So essentially he has rest pain with that, so Rutherford category 5 symptoms. Again, usual medications, CAD medications, and no known drug allergies. Next slide. Physical exam, essentially nothing too serious except for the fact that he had a systolic murmur consistent with his AS, and he had bilateral Dopplerable pulses, DP and PT, and he had a left big toe dry gangrene, dry black, around like half a centimeter, like a dime size black gangrenous non-healing ulcer. Next. I mean, not a gangrenous, it was dry gangrene, yeah, non-healing ulcer, yeah. Next. So we're going to, go
George,
on to, yeah.
I want to get to the case. So as you know, this guy has got he's a typical vasculopath. He has he is on dialysis, severe peripheral vascular disease. He has an extremely painful ulcer on his right foot, and you'll notice how much he moves his feet. Obviously, we're treating him with all the medications. And he had an attempted endovascular intervention at outside, which they failed. So they offered him an amputation. So at this stage, I'm going to show you what we have. He's not a surgical bypass candidate because of his severe coronary ischemic heart disease, and also his vessels are very, very calcified. So there's no opportunity for our surgeons to be able to do an open procedure on him. So he's been turned down for surgery. I do want to show you he had no inflow disease. We did a diagnostic, obviously, in preparation of this case. We have a 7 French sheath up and over. We only went with the 7 French just because of the fact that it's a live case and that we want to be able to illustrate, at least with angiograms, what we're doing. So you can see here he has a calcified SFA, but really nothing non-obstructive. They had done a stent of his popliteal in the past, which is widely patent. And then you can see here as he's moving, you can see the popliteal stent is patent. And below the knee, at the trifurcation, there's no vessels that exist. And then you can see on delayed filling, the posterior tibial and the perineal artery coming back. And I think you're going to see that better in this picture, or maybe the next picture. Let me see. Here we go. There it is. So in this picture, you'll definitely see it. You can see as we inject dye, you can see there's a collateral coming off the popliteal. It's a low takeoff anterior tibial, and then the tibioperineal trunk is occluded. And then he has 2 vessels, both the perineal and the posterior tibial, that comes back. As you go forward into this foot, you see that he has diffuse disease in the feet. The posterior tibial is a dominant vessel that goes into the foot, which I knew that we could revascularize this posterior tibial. We weren't worried about that. But the anterior tibial is heavily collateralized proximally, so therefore it's the real challenge. So we felt, especially with this microvascular disease in the foot, which you'll see in the next picture, you'll see that the arch is very, very poorly formed. Actually, the dorsalis pedis is what is going to try to supply the ulcer area of his great toe, which is what we're trying to save and prevent a major amputation for this gentleman. So at this stage, we went ahead. I put a catheter down to take better pictures for you guys. You can see here he really has nothing except a short segment posterior tibial, which again was we didn't feel would be much of a challenge to cross. But however, the anterior tibial is quite challenging. And then so what we decided to do offline to make the case go quicker is that in the last 20 minutes we just went ahead, used what support catheter?
Teleport.
The teleport catheter. I don't know if you've been using it. The teleport catheter by CSI, I believe. It's quite trackable. It's a great catheter for the coronaries, which we've been using it in the peripheral. And then you can go ahead. You can see we injected some dye, and all we did was that we were able to cross this actually without much effort using a Fielder XT, the jacketed wire that they were talking about in the past. We didn't have to escalate to an 018 system at this. So at this stage, we went ahead. We just said, let's go ahead and do a test to make sure we're there. We did a laser, a 1.2 laser here, and then we went ahead and did an IVUS, which I'll show you, and then we went ahead and do a balloon angioplasty and a chocolate balloon. Of the vessels, and I want to show you exactly how it looks here after we did that. So once we did the chocolate, we have straight line flow in the posterior tibial. The anterior tibial, you can see, George, it's there. You can see that it's coming back, but it's very dissected by the multiple interventions that they attempted on the outside. So I tried to put a wire down, and the wire was kept on going into the dissection planes. Dr. Guja, Dr. Kapoor, and Asma all agreed that this is the kind of lesion that we should probably attack from below, cross it from below, and then be able to externalize the wire and take a look. Can you just play the IVUS quickly, please, before we go to the access? I just want to show you how calcified these vessels are. The good folks at Philips are here to help us with this IVUS here. And you can see here that it's a heavily calcified vessel, approximately around 3 millimeters. And you can see as you come proximally, we were able to cross without much dissection, especially in this area. You can see there's a little bit of a dissection there, but again, not horrible, not very flow limiting. And that's why we went ahead and measured this around a 335 vessel, and we went ahead and did a chocolate. Our eventual therapy for this, we'll talk about it, but we firmly believe, with his toe pressures being so low, that clearly that his arch is very, very poor. So with his arch being very poor, we really feel that we need to open this dorsalis pedis artery and with straight line flow from the top in order for him to heal the wound, or at least heal an amputation of the toe. So that's where we're at. So just to tell you what we're going to do, Dr. Guja and Dr. Kapoor are going to demonstrate access, and I'm going to turn it over to them, and I welcome the panel for any questions, or yourself as well, while they start working.
Go ahead, Vishal. All right, go.
Yeah, so PK, great work so far. I mean, I think you've hit on a really important point that I think used to be more controversial than it is now, and that is, if you'd had a better arch, so let's just suppose you had a better arch for collaterals, would you be as willing to, or feel like it's as necessary to get the anterior tibial distribution through if you have collaterals, right? So we know if you have an intact arch that you're not going to really get the job done, or it'll be difficult.
I totally agree, George. I mean, the problem is we don't have a good perfusion assessment at this stage, and this is kind of the challenge that we face. I'm an interventional cardiologist, as are you, and I'm sure most of the panel is as well. And in ischemic heart disease, we're able to tell the burden of ischemia. We're able to tell the adequacy of revascularization by doing an FFR and showing that there's no residual ischemia. In this kind of situation, we're really left to our things, and I'm going to ask Dr. Guja to talk a little bit about that. And one of the things that we feel in our CLI practice here at Sinai is really try to get complete revascularization and really see the arch very, very well at the end. And in this kind of incomplete arch, we really feel that opening up this dorsalis pedis will give him the best opportunity. Before we make a comment, I'm going to have Dr. Kapoor go over the ultrasound, because I think it's a very good technique that we're utilizing more and more. The one caveat I do want to say at Sinai, we don't do primary intervention from the foot. We generally do, use the foot for access to cross. I know there's a lot of talk in the community about doing interventions from from the foot. We tend not to do that. We use it for particular reasons such as this, where we know that it's going to be prohibitively difficult from above, and/or multiple attempts have failed. So rather than spin our effort, we're going to go ahead and do something. So Vishal?
Yeah, all right. Thank you, everyone, for having us. So as you can see right here, you can see the anterior tibial artery. It's actually the dorsalis pedis with the two veins on the side. Best to demonstrate is try to compress it. Oh, he moves a lot, so sorry about that. But you can see when you compress, both the veins compressed, and you can also see the calcification in the median wall. I mean, I'm sure when you have dialysis patient, even the veins have calcification, but it's a good marker to differentiate between a vein and an artery. And sometimes even the artery can be compressed if you have really collateral flow. They don't have much pressure. So what we're going to do is we have a hockey stick ultrasound catheter, which is a great catheter, a great probe to use, especially for tibial accesses, very high resolution. So we already numbed up, and we're going to try to see if...
So Vishal, can you talk about what is your equipment? What are you using other than the hockey stick probe? What needle?
Right, so we have the micropuncture needle. We actually can either use a 4-centimeter micropuncture needle, which we use for the radio, or you can get a Cook sheath if you're in a Cook sheath believer. It comes with a micropuncture, 4-centimeter micropuncture, 4-centimeter needle as well. So, and then the goal is to try to get a dilator in and see if you can work through that. So you can see I'm trying to see, that's my artery right there. So you can try to go under radiography, or you can try to do long axis to try to see if you can pull off.
So this is the long axis view. You can see the vessel very clearly now.
Right.
And you can see the patient is moving quite a bit. Again, it is a very painful ulcer. So you can see here Dr. Kapoor is tenting the vessel, and you can see the radiopaqueness of the needle as it comes through. So now, do you have blood flow now?
Yeah, we have good blood flow back.
Good blood flow. It's very common, and you know, George, I'm a little bit of a dinosaur. We tend to do it under fluoroscopy, and when you do it under fluoroscopy, you clearly get into the veins more often than not. That's our wire in the posterior tibial. You can see here, Dr. Kapoor is now going to go to fluoroscopy and see whether we can get in. So we're using the dilator here, the wire that comes with the micropuncture kit. So it's very important to understand that you don't want to push this wire without watching it on the fluoro, because what will happen is you'll create a retrograde dissection plane, which you don't want. Now we're not sure where this is. This could be the vein. Yeah. And let's take a picture. And I think it's important to show. Let's take a DSA shot, guys. And I think no, just from below. No, you don't need to push it up. That looks like an artery. Yeah. Exactly the way it occludes. It looks like. But let's take a picture.
So, we can take a
picture. Actually, let's not take a picture. Let's do it on an ultrasound. And I want to show the wire in the artery. So George, these guys demonstrated it very easily, but this takes a little bit of practice.
See here, that's your artery right there with the you can see the radiopaque wire in the middle. So
okay,
it keeps going.
Can you go longitudinal so the audience can see it better?
Yeah,
because longitudinal, I know that a lot of us can see it better in the longitudinal axis rather than the transverse.
Yeah, it just becomes a little...
Yeah, I think it's harder because you got the...
There, right there.
There it is.
So that's your medial calcification, and you can see the wire with the radiopaque shadow.
Okay.
You can even see
the guys on the panel, is this how you guys get fetal access? You use ultrasound, or you use fluoro, or you use a combination?
Well,
we follow the wire all the way up, and you can actually get to the cap. Look at that. And at this point also, all of them are making kits. The Terumo has one as well. And the Cook one allows you, including with the balloon, to do even a full French balloon from below, IVUS from below, everything else. But the Terumo slender sheet, which is a 5-6 or 4-5, you can do IVUS through it, plasty through it, atherectomy through it.
Yeah, we've discussed that. So there's two camps. Some want to cross from below and work from the top. And
what do you guys want?
Romy, we generally don't get access from below in order to treat. We just try to cross from below. I know that a lot of people are doing that. I don't know, really. I'm not judging or anything. I just don't know what's. Get the whole thing here, guys.
Yeah.
I just don't know.
No, I agree.
What the right thing is.
Keep your access profile down there as small as possible.
Right.
We almost never put a sheath. The only difference in technique that I use is I use it under ultrasound. The wire that I prefer is a V18, and I'll usually take the needle out and put a CXI, no 1/8 CXI on the back end of that. So I don't even use the dilator, but the profile is probably the same or smaller.
But you're taking, when you get needle access, that's the wire you're
taking? I mean, that's something I learned from Craig, is you take a V18, go up, If you cross from below, that's great. If you don't, you can just take a CXI, backload it on it. You don't increase the
Take a
profile of
micro.
your distal.
I usually like to at least have the little
Beta.
and I'll take an 018 Gladius.
Give us
Sure.
give us a
I mean,
grandson.
you can do anything. So it's my principles are saying keep it as low profile as possible. Distally externalize the wire and come from above.
So I think there are two groups of patients. A 450-pound patient can't puncture his femoral.
Right.
Nothing reached from the radial.
Right.
So my best choice, a very similar disease, did everything from below. So the cooked sheath kit, actually the dilator conversion to the sheath. It's almost just full French. But if you want to go slightly bigger, do IVUS, etc., then the 4.5 can slender sheath work.
Yeah, I mean, the
as well.
4.5 slender, I mean, you know what kind of vessel size.
I'll just take a command.
Almost everything you want to use shy of atherectomy.
Yeah,
Go through that.
go with the feeder also.
But I think Pete's point, which is well taken, is the most crucial part of the circulation is what he just asked,
Exactly.
right? So if you mess it up,
Don't
then
mess it
this
up.
whole thing is for no.
We also actually use a
No,
radial
it's not the sheath, it's
cocktail,
the dilator.
The dilator itself.
some
No,
heparin,
it's a pedal axis.
vasodilators as well.
Yeah, that's a pedal axis.
So what we've done, guys, we've given the vasodilators. We're using the dilator of the sheath. Dr. Guja is inserting it. I'm just holding his foot so he doesn't move it. And then, hold on, sir. I'm sorry. I know it hurts. And so what we're going to do now, show me below, guys, please.
With a microcatheter? Yeah.
And so what we're going to do now is try to get this in. It's not going.
I know it's
Okay.
calcium.
We can use a
Very,
stiff.
very calcified.
Stiff,
So
you
I
want
think
a
in this
stiff?
situation, we may just go with an 014 wire. And this is kind of the challenge we face at times when it's not going to go. And okay, there you go. Good
Yeah,
job.
it's fine.
All right, so let's give us the 018 wire now. So we're gonna we generally try not to use 018 wires, especially I know Craig loves this wire, but it's not crazy. We're not crazy about it. The V18, we feel that
bend, right?
it's got a crazy bend, but we'll be okay. We feel that it kind of goes where you need it to go, but however, it's gonna go somewhere. I can guarantee you that. So what we do is we generally get this up to the level of the occlusion. And then what we do is we will put an 018 trailblazer through this, and then switch the wire out. Somebody walk this out,
Do you
please.
want to take the CX?
Yeah, take the.
I like the trailblazer. So let's go with the trailblazer.
So
So
you can access, then you put your CXI or Trailblazer up, and then you switch out to whatever wire.
yeah, exactly. So I think it's very important for the audience, to have the a access that's big enough or a catheter that's big enough to be able to track whatever wire you want to do. In this case, myself and Dr. Guja both feel a hydrophilic wire will be enough to get the job done. However, you don't know, and you have to be ready to come from above and below and do a cart or a reverse cart technique as well. So at this stage, Dr. Guja is giving me this. I'm just going to go ahead and put this in. Don't pull the wire out, please. Okay, rail the wire, please. Wire's way back. So we're just going to get this in, and there it is. Okay, now we're going to check out for a safer wire. Give him let's give him a command. We'll go with a command wire from below.
You can
So
take an
I'm
018
going to try to
command.
cross with the hydrophilic wire. What's
You want
that?
to take an 018 command?
No, this is an 014.
014.
This is an 014.
This is an 018. This is an 018.
Oh, sorry.
Yeah.
018.
014 command, please. So it's torqueable. So we generally start again. I don't know what you guys do. Our technique is to start with the lowest gauge wire first. We go with an 014, then follow it up, and then escalate it to an 018. I don't know if you take a look and decide what you want to do. But in this case, with the level of the dissection that's there, I think we'll just go ahead with an 014 wire and try to find the plane and take it up. Because we know that the old film that we looked at, they tried from above and they were into the collaterals and by the side of the vessel. So, one of the things is that at that stage, we felt that we would probably go ahead and get into the same situation from above.
I mean, I
Do
don't
you ever
think
use road mapping?
What's that?
Do you use road mapping? Do a road map. I'm sure your machine has that capability.
Oh, you
From
want
above, you already have.
Yeah, we could use roadmap. I can inject from above and do a roadmap. I mean, we're going to go ahead and do a roadmap right now.
Except if he's moving so much, your roadmap's not going to really.
That's a good point. So there it is. So it's a long segment occlusion, and around 25 is the cap.
I think the 018 already crossed it most of it.
So we'll see.
Yeah.
So you want me to track? Oh, okay. Yeah, he's moving a lot. So at least we get an idea.
I think your 018 did the job, PK, already. So.
Here, give me the torque here.
I have the torque.
So the problem with the command, at least in my hands, I need a torquer every time, unlike our coronary wires, to cross this. So we're going to go ahead and work with the command here. I think that's maybe in a different plane. Might need an 018 wire with that level of calcium.
What's your decision-making process to escalate equipment?
For me, it's calcium. Generally, in this case, we felt that there might be a channel to go, but with this level of calcium, I tend to go with an 018 wire or with an 014 CTO coronary wire. So, that's generally what I do. I don't know if you guys do anything different. The other thing you could do is go ahead and take this out. All right, let's go ahead and take this out. Give a little more diaphragm inside. Get me a WIN wire, please.
I have 018.
You want to try an 018?
I think we crossed most of it on 018 topic.
You want to contrast?
That's the die.
So one of the other techniques, Truma has a 014 advantage wire, which is a glide in a stiff body. I let tip buckle up and then push with the catheter and kind of push through the cap. So it doesn't dissect into a plane, but it'll make a plane. It's like a blunt.
So Romy, you're essentially
Careful.
I think it
Maybe a fielder would go.
It's nice.
Maybe fielder.
Same
Fielder.
right.
Fielder.
Yeah.
018 nicely.
Yeah, we use the Terumo Gold most of the time, and that's exactly what we do here, which is an 018. But we found that it's a lot less traumatic and a lot less prone to get into stupid planes.
Yeah, I've kind of quickly transitioned to 018. I've just found that I can't get across a lot of these really messed up lesions with an 014 wire.
Yeah, you see this right here? This is what I mean, George. See, at this level, it's an eccentric calcium. And I think with this 018 wire, we're going to end up dissecting this. I think it's better to go with a nice coronary 014 and track it through. So give me a coronary wire, please. Give me one of the fielders.
Fielder.
Okay, if you let that catheter buckle, would it create like a nubbin and just push it through?
You could,
You
but
ever
I
tried
mean,
that?
but yeah, we have. But I mean, we generally do it when it's an occluded vessel, Romy. And here we have a vessel that's not occluded. So we feel that we can track this through without creating a dissection plane from below. Because our idea would be, I think we're definitely stenting the ostium of the posterior tibial because of the way it looks. But in this, it would be nice to get away with a nice prolonged balloon angioplasty and leave it with that, which just gets straight line flow to the foot. So I'm just trying to see whether we can sneak through this. And then the other thing also that's happened to us is in these kind of situations. Oh boy, this is a pain in the neck. In these kind of situations, I think is also to go with a take floor guys is to go with a sharper wire, a Confianza type wire, and then try to work that. So we're gonna go here.
So PK, just a thing. I mean, in the beginning we use a lot of non-braided catheters from below, something like a Quick Cross or a Trailblazer, but we quickly switched out to something that was more braided, because if your Trailblazer kinks somewhere in, then you're done, if you take your wire out. That's really good.
1 second here. We're just
So
going to
what
take
wire
a
did
picture.
you use again?
This is just a hydrophilic wire that me and Dr. Guja felt would go. Why'd you come off floor? Take some picture from above, please.
Field.
I just want to see. I think we both felt that we'd have a good chance here. And you can see here, we're getting into that branch. We just need to try to make that turn right there. And this has been an issue from above and below. So.
Hey, you're right there.
Nope.
Maybe the catheter. You want to take your support catheter?
Let's try to take the support catheter. Yeah. I'm just going to put it into the collateral and let Guja push this up. If it goes,
I got it.
It may not go. So we might, you know what, guys, give us the teleport back.
Yeah.
And I think this is where the teleport's going to be amazing.
Yeah.
You're going to see it. Give us the teleport back. Yep.
Okay, show me.
So we're going to walk this out, and we're going to switch out to a teleport.
Yep.
Now, Romy, you may be right. I mean, you could probably balloon this from below, but I think you would have to put that 5/6 slender sheath in with in this kind of very diseased arch. I mean, I think it's an amazing catheter, but we just don't feel comfortable.
Actually, no, with the faux French kit, you can just put their faux French balloon over the same 014, the same kit, the same access, and you dilate it.
I got it.
And I've used the Armada 1 millimeter balloon as a crossing catheter and dilated as well.
So what we're going to do now is we're going to put this teleport catheter in, and then what I'm going to do is come from above with the catheter. I'm going to ask Dr. Guja in a second to go ahead and come from above with a catheter over that wire that we have in the posterior tibial. Then we're going to externalize this wire. We're going to work from above. This way we'll have sort of like a through and through kind of, body floss kind of situation. And then we'll go ahead, balloon angioplasty, see how it looks, and then take it over. I'm pretty confident we'll be able to cross the posterior tibial again without stenting it. Or if you guys think we should stent it first to maintain access, we'll do that too.
What's your anticoagulation right now?
Right, that's a great question, Romy. So what we do all of our work on Angiomax. We've always been a big Angiomax lab. Dr. Sharma has basically done most of his coronary CTOs on Max as well, obviously, albeit a little bit of a lower dose. But I think we've seen the safety of Angiomax in this work. And so therefore, I'm very confident that we'll be able to be fine. We often turn it off and on. Is it not going? We often turn it off and on, and you know, based on how we're doing. Even there it goes. Okay, come on, let's go.
I don't know how everyone else feels, but I would be biased to just fixing that posterior tibial, and then you don't have to worry about it, and then concentrate on the anterior tibial. But
so I'm going to let Dr. Guja go ahead and stent the posterior tibial. Yeah, guys, give him a coronary 3.5 38 stent, please. So that was the question I wanted to ask you. What do you think in terms of stenting these coronaries? These tibials. Forgive me. How do you deal with this? When do you decide to do one or the other?
So I've always used a lot of coronary DES below the knee, and it hasn't worried me, and I haven't really run into a lot of the trouble that people talk about in terms of stent deformation and crushing. Now, I don't take it very far downstream, obviously, but I think the lesion you have is a very straightforward coronary DES case. I guess the question I was going to ask you from earlier today is, if you had enrolled this patient in a trial, you know, if this was like a Saval type patient, I mean, what do you think about, you know, the state we're in right now with paclitaxel coated products?
Well, you know, I think that's part of the reason we did not present a paclitaxel case, because I think, you know, obviously below knee we don't have a paclitaxel coated balloon. So in this case, I think, you know, obviously it's not relevant. It's not going to go, guys. It's not relevant. But you know, in my SFA practice, we have stopped using it because of that really strong FDA letter that came out. We do get informed consent on these patients, and there are patients who have very, very complex disease that we go ahead and use paclitaxel on. But it's pretty much been only in those patients that we do it, and no one else. I don't know if it's any different with you guys.
But PK, I'm talking about if you're trying to enroll this person in the below the knee trial, would you feel comfortable at this point enrolling someone like this in a below the knee trial where you have a paclitaxel stent in one arm and a bare metal in the other, or would you just not enroll the patient and just use a coronary sirolimus or everolimus type product?
No, I would definitely, because I don't think it's relevant. I think that we definitely don't know whether the paclitaxel is going to cause this mortality below the knee as it does above the knee, at least from this meta-analysis. So I think that I would feel very, very comfortable enrolling this patient in the upcoming trials that we have. So I don't know if that's what you guys feel as well. You know, I think that, you know, first of all, I want to go on record by saying that it's a concerning signal, but however, it's a meta-analysis, and all the deaths have to be adjudicated. We know that paclitaxel, you know, has been used in breast cancer and in other cancers at much higher doses. We've got great experience with paclitaxel in the coronaries that we have not seen these kind of things happen. So to me, it's a tragedy because we're going back 10 years in my practice. I mean, we waited forever to have this ability to tell our patients that we'll be able to limit our restenosis, and now all of a sudden, you know, it's gone. So I really feel that, you know, I wish the FDA had given us an opportunity to continue using it, and really maybe putting a registry where we would follow patients out to 5 years and mandate that we do that. And also, I wish the companies would have done a better job in terms of adjudicating all the deaths and presenting it. I know they're doing that now, but that would be you know, something that I wish would have happened earlier.
Well, I'm glad. So two things. Number one, I'm glad you said all that you said. So you make me feel good about the talk earlier this morning. So we're not counteracting each other. Now, are you doing a separate consent? So for paclitaxel?
Yeah, we are. We're actually, I don't want to jail the AT guys. What we're doing is the hospital is in the process of doing a separate consent for paclitaxel. But in the meantime, what we're doing is in those cases of recurrent restenosis, what we're doing is we're saying to ourselves, okay, let's go ahead and tell the patient that we believe that this is the best possible therapy for their you know, how could you say, to prevent restenosis. So that's what we're doing. And so we're doing kind of a two-edged, a two-pronged arm.
Okay. So what stent? What stent did you pick?
Well, this one is a Zions 3538
3538.
Zions stent that we use. Obviously, we can use any one of the stents that are available. I believe that this stent has a lot of data. But the reason we stented this is now what we're going to do is, since we're having trouble advancing the balloon, is we're going to come from above, because now we know where the CTO is. So what I'm going to do is I'm going to go ahead, put a 014 catheter down from above, pull this wire out, change for a hydrophilic wire, and try to meet the wires, and maybe do a cart or a reverse cart. So now that we've secured this, I'm gonna switch with Dr. Guja here, or actually let's go ahead, let Dr. Guja walk this out, and then we're gonna go ahead and put this what is this? Fine cross catheter from above. Let's go from above with a fine cross from above.
Below.
I'm sorry.
Just trying a ordinary balloon from below.
Yeah, but
So the idea not to do that is you don't want to put a sheet down there, right? So you want to right now is he's just trying to keep the access profile down as low as possible.
Well anticoagulated with Angiomax. We never had a problem. We can put the 4-5 sheet, put a 1 or 1.5 millimeter.
Just enough to break the calcium over there.
Yeah, you know, we've used the Avid balloons in 1.5 millimeter. You can dilate that calcium and get a wire through.
I think coming from above, he's going to meet those wires without having to do anything from below. I think the minute you put an antiquated wire up there down the angiotibial, you're going to be through. It's not going to be an issue. And reverse parted.
So just on the attendees, it's not too bad to do stuff from below. We do it all the time. Just have to be careful.
Hold it. Hold it.
I mean, Romy, I got to disagree with you. I think people are doing too much stuff from below without any true indications. I think the distal vascular.
Yeah, the analogy I gave it is, you always go through your front door. Just because you can go through your window doesn't mean you go through your window every time.
That's true. I mean, let's get a fielder.
This
is this one.
Yeah.
Let's get a fielder. So what we're going to do is get a fielder wire, please. So what we're going to do is we're going to go with a fielder wire. And then we're going to go ahead and try to meet the two. And once we get into the true lumen, I think working from above will be easy, because now we've identified that everything else was a dissection plane from below. Get a fielder, please. Wire introducer.
So just sort of, did you consider an antiquated access on this guy, given that he had no inflow, especially since he's got bad, distal disease, inframalleolar disease? If your arch is not complete, if you have an antiquated access, you have some possibility of trying to revascularize that, or is he just too big a patient? You're not going to be able to do it.
Our antegrade access, we do have antegrade access, but in this case, I mean, we felt that we would have enough pushability. He's not very tall, and now with it's coming back with distal access. I'll hold with distal access. Like we did now, just to help us cross. It's our need for antegrade access has gone further and further down. That's all. So I think that there it is. Okay. So now I'm going to let Karthik go ahead. I'm going to get Karthik to get that down, and then we're going to try to wire it. That's good. There you go. That's good. See, that's exactly what was happening. So right now is a good place to do a cart, maybe, balloon from above and try to go. Karthik is going to try to wire this, and I hope he does. But it's very difficult. There you go. Oh, see, that's another dissection. That's another dissection plane. So that's what, when I saw them do it on the outside, they were getting into this side branch right there. So one thing I've done is I've pulled the wire from below and have the other wire kind of track up. So what I could do is, in order to help Karthik, just slowly pull the wire from below. 1 second. Okay. So let's mag up high, please. Mag up really high. Okay. Shutter in. Okay. Now I'm going to pull the wire from. Let's see if you're there. Just slowly pull the wire. Pull the wire. No. See, right to come back. Okay. Stay right there. That's my tip. Now come on. Let's go. Ah, boy, right there, huh? Should we do a cart from above there?
Yeah, I think you probably are going to have to.
Karthik, your catheter is too high.
Yeah, I know. Pulling back.
No, your catheter is too low. All right.
I'm pulling
I think the other option is whether we do it over here. Can I give a torquer on this?
Yeah.
So what
the other thing is you just pull back your support catheter from above. That channel that you've made, your wire from below may just find that same channel because.
All right, so I'm going to do that from below here. Pull your catheter back, please.
But doing a reverse cart, I mean, just ballooning the top with a 2530 balloon, the wire from below is just going to find its way up.
Yeah, but I got to tell you, there's something going on here that's a true issue. I think that the only way to do it is to go ahead, maybe go with a confianza from above. Yeah. All right, guys, give me a confianza from below. So why don't we put a balloon up there and balloon from above
I
at the
think so.
level where Dr. Guja is? So let's change this out for a balloon.
Hold on.
This is part of the nuances, as you guys know. This is so difficult that sometimes you're so close and you're not able to get through.
Something is wrong.
So Romy, the other thing, even if we were able to put a balloon from below, the problem would be that we would still have that problem up there, Flora. Right there. See where there it goes. You might.
Can you do a run there?
We can do a run from above. We'll give it a little dye, guys.
Or even inject a catheter from below. See where you are.
No, but I think this is the same thing. Say, see, Romy, you're right next to it. You're parallel.
Yeah.
Yeah, that's
You're
the problem here.
That's the plane.
That's the plane. It's the plane that was created. And for all interventionalists, can I see below, please? For all interventionalists, as once the plane is created, it becomes very difficult for us to deal with it. Now, see, the hydrophilic wire went, but the CTO wire won't go.
That's a combination from below.
Yeah.
So PK, just out of curiosity, why, if you leave your hydrophilic wire from below that you had into that small branch,
Give me a
and
new
from
field,
above
please.
you are slightly subintimal, you
Field
take
of
a
XT.
XT.
No, don't push.
No, I'm not.
you take a 2.5 balloon from above, you would have broken that plane, and your hydrophilic wire from below will crack up.
Yeah, no, that's why I told him. Go take an 014 catheter.
Get an oven for.
Oh, now you got it.
This is
Flying
on
cross.
four.
The thing I keep thinking about those, I'm getting
okay.
the cross successfully,
Go. Hold on.
and we're just stuck with a long POBA.
Which is
Think about it. You in a coronary situation, you would never do that, right? So that's our option here. So the best case scenario is you cross, you do a long POBA inflation, and you hope it stays open long enough to heal.
I don't think that's the
It's
problem
not
here.
going to really be a great.
So the other question is, how long do you keep trying with contrast load, etc.? And then when do you say, okay, I'm going to wait, see how he does,
Pull it
come
back.
back?
Please. Keep-
Because another technique to do here is put an ultrasound probe on there, see the cap, right on
Yeah,
that
do
anterior
it.
table.
But Romy, we've crossed the cap here. See, the cap is.
No, I know, but you just get a feel for it. That's all.
See, the problem here is not. Give some dye from above, guys. Yeah, now it's going to be more of an issue.
That's the calcium right
There
there.
it goes. Oh. That's the horrible calcium. Whatever reason is not going. Give me a regular field. It looks like field is the only thing that's going.
Just take the field up and then change it to 014.
So PK, did you guys get any sort of tissue oxygen type measurements to know exactly what's going on? So I think what Rome's looking at is at what point would you stop, reevaluate, and at the end of the day, if it's just a toe amputation versus a midfoot versus a BK, it's a big deal.
And then even though the arch is not complete, there still is some extra perfusion now. And just see where it goes. Whether its pain goes away, it's painful ulcer, and then try it another as well.
You can take a
It's wriggling his foot anymore.
Like a caravel or something. Take a caravel.
Yeah.
Give me a caravel, guys.
So there's a lot of talk here about going with a 1.0 balloon, the coronary 1.0, the Boston, or the 1.0 balloon kind of bareback, if we can get this back up, and then going ahead and ballooning it from the foot. But I'm a little uncomfortable pushing the shaft through this calcified vessel without a pedal access. So that's kind of what we're thinking here. Torker?
Torker right there.
PK, why did you reverse pocket? You got your wire from above, slightly subintimal past that cap. So you balloon it from above, and your retrograde wire will track up.
I think just
straight,
loop it and then.
Yeah, I think that's what we're going to do. We're going to end up waiting with guys.
If he's not moving that much, do a roadmap, you might see it again.
A little higher?
No, so they're
Higher.
Okay, now we got to come from above. Let me try from above. Give me a comprehensive from above,
let me
guys.
fix
Flora, look out, please.
Yeah, take it.
Make confianza.
We're going to try a comprehensive
No,
from
but-
above. Higher, please.
Just try the Armada from below. It acts like a crossing anyway. It has a 1 millimeter balloon.
Right here, we could balloon it. I'm saying, I think right here at this stage, go to another view, guys, for me. And let's see whether we can balloon it in this spot. Let me pull this back, and let's see if the wire goes here. See, right there is the dissection plate. I think there's a big collateral. Give me a comprehensive. Let's try it with a sharper wire.
Here.
And then Romy, if that doesn't work, then we'll go ahead and balloon it with below. Can one at a time, please?
So you could balloon it from above, right?
I mean from above, not below.
That's his torque for him.
If you keep the main thing is that it's patent flow from below where the wire's going to the side branch. So if you bring the other catheter down below the takeoff of the side branch, you'll straighten the vessel.
Shall hold this catheter for me?
Yeah.
Yeah, and even if you're at some
Because
point
I think the bias
in and
is
out,
what
you know
you're-
at this point you're in, right? 'Cause
Right. So you can.
I think that there's got to be a collateral here. Karthik, give me a dive, buddy.
That's quite possible.
It is, there is a collateral.
I think. That's it. There you go. Oh,
Same thing.
But that's where you went out.
That's
No,
more
there
No,
you
no,
go.
no,
Now you're in.
it's looking like.
give me a.
But
You know what?
remember,
I'm gonna go ahead and push
Okay,
this.
we're in AP view.
Okay, let me push
Yeah,
it.
mhm. I'm gonna go ahead and get this down. Go further. Okay, let's stop there. Get the torquer, please. I think sometimes you need that little push of a catheter. I think we're not quite there, but at least if we get it closer, we can go ahead and do a cart down here. Maybe that may be the way to go.
with a longer balloon.
Yeah, with a longer balloon. That's what I'm thinking.
Yeah, can you?
Maybe a hydrophilic wire from here, guys. What do you
Yeah.
think?
No.
Maybe with a loop.
No.
Give me another a looped wire here. Give me another Fielder XT. Yep, we're gonna have to go pull it back, Vishal.
Yeah.
Yep,
I
let's
am-
come
I am-
back
I
a
am
little
on.
higher.
No.
All right.
I think that's good. No.
See, right there, it looks so good. So what?
There it goes up.
Why don't we take this down and try to leave it right there?
Take it a little bit
Now
more
come,
down.
no, let's pull this from below. Try to wire it from. Try to wire it.
Do you ever consider pulling that top wire out and injecting a little contrast to see where you are?
We could do that right now. Pull it back, Karthik, a little bit. Come, now. There you go. See? There you go. Perfect.
we are in.
See,
We
that's
are
what I
in
said.
the
You break
catheter.
now I'm going to pull it. Now we're in the catheter. Now we're going to externalize the wire. Push the catheter. Push the catheter. There you go. Beautiful. Wait.
Yeah,
Let me
I'm
pull
not-
this wire out.
Hold on.
There you go. So I think this is kind of, the fun thing that you can do sometimes. Push it down now.
Okay.
Karthik will push it. You push this way.
I'm gonna push. Hold on.
I'm pushing, you can push. I think that's where we're going to have
That's
the
where you're going to
resistance.
have the resistance.
There you go.
Keep
You got
coming.
through. Keep
A little
going,
more. A
keep
little
going,
more.
keep going, keep
A
going.
little more.
Keep
No?
It's buckling in the top.
Buckling up top, huh?
No,
Okay.
that's because my catheter is here, no? PK.
I don't
So,
have the
My
wire.
catheter
Hold
is
on.
here.
so we're going to kiss the catheters, and then Karthik is going to push. Okay, kiss the cat, push for positive.
PK likes the word kiss, guys.
I push.
The last few
No, I
hours,
don't have
all I've been hearing is kiss and pull and push and crush.
Is it
and
coming?
I
kiss.
don't have the wire.
Can you go?
Yeah, I'm going.
Okay, well-
I'm going. Vishal, check it out. I think you should get it through with this.
No, it's not coming yet.
No.
Push forward, Vishal, the catheter. No, it's
No,
not
it's
going.
buckling.
That's
It's
very good.
buckling.
But it should come through that.
All right, so we're going to try to externalize the wire now. Let's
Yeah.
walk this out now.
You, PK, you have
You
to
can
push it.
externalize the wire and it can, you already opened up a laser. You can get the laser to get through that.
Yeah, exactly.
Take a
You gotta
channel
walk
and
that
then.
out.
No, I can't walk
Oh, you
out.
can't push
Yeah.
it yet. I see.
Yeah, you-
So what
unless you
Dr.
have the
Gupta is
wire.
doing is pushing the catheter from below up. So Vishal,
PK, do you have wire pulled out from your sheath on top already?
not yet, buddy. We're still waiting for the wire to come. So what we're going to do is we're going to go AP, and we're going to look at the sheet to see whether it's coming while Guja's go ahead and pushing from this end. If we see it at the level of the sheet, we'll be really happy. And it's still not there.
Not there.
It's not there yet. So the only question is, is
check
it
it out.
somewhere else over here?
No.
Nope, there it is. It's through the sheet. It's still
No,
coming.
It's through the sheet. It's still coming. Just check it
takes
here.
time.
Let's go low mag here.
Check it here.
Because once you have it, you can you'll have it flocked, put a balloon from above, and just dilate at that spot a little and push further.
It's coming
The
now.
other, the other thing I think
There,
that
PK.
PK, you guys should be commended
No,
for is
there it
just
is.
being
There it is. Keep coming,
persistent with
push,
wire
push.
isolation, to not be lazy and knuckle it and shove a
Push.
catheter because
Oh, you're out.
that
You can
may
pull it
get
out.
You can pull it out.
Yeah.
Vishal,
It's full.
you can pull it out.
No.
Yeah, we came out.
So we got it now. So it's out
Right
now. So now what we're going to do is we're going to put a coronary
Clamp.
balloon on this end.
No.
You got it? Okay.
Yeah.
So
One
let's give
second,
us a
Vishal.
2 ohm
Vishal, I'll give you the
balloon.
catheter. I'll give it to you.
Actually, just
pull your
wheel it.
wire.
Let me see if I can
Pull
push
your
this
wire.
up.
No, just take it out. Because Vishal, you pull it. I'll pull this.
Okay, so
clamp.
now what's important is you have to put a clamp at one end, and then Vishal will pull the wire, and I'll
the
feed the
catheter
wire
in, so
forward
it's
as he pulls. Go ahead, pull. Keep pulling. So what I'm doing is I'm feeding the wire to Vishal, and I'm going to put a clamp on the end by the toe, and then we're going to go ahead and just balloon it. We'll be done in a minute.
Take the
How long
wire
is your
and
wire?
The other way.
This is a regular 300, the wire. You can pull.
I got it. I got it. I got it from you. I got it clamped.
Can we
Regular
use a
300.
coronary balloon or rapid exchange?
I'm definitely going to use a rapid exchange. Give us a 2030 coronary balloon, guys. That's fine. That's fine.
Sometimes
That's more than enough.
we use the over the
Give me the
wire only so
microcatheter
that
here.
change the wire. Never need to.
Just put a microcatheter down and we can exchange it for a regular
So now
one.
we're
Give
just
me
going to
a-
go with a 2030
let's-
balloon first.
Give me
And then
take
after
it down.
that, we're going to go with a microcatheter
Take
and
it down.
exchange it out.
I know. I'm going to put this and put a tegadum here.
So it's one of the challenges we'll be loading on the soft part of the wire here. So the soft part of the wire is a challenge, and my eyes are too old to see. So Vishal is at least 10 years younger than me, so he's got good vision, right, Vishal?
Yep.
So
Vishal is a
okay.
short guy of all anyways.
No, solve the
Yeah.
wire out and just use the steps
Okay.
on both
You're okay?
sides and put a
You know-
clamp in the other hand.
So I think that that was a good technique that you saw where you have this body floss through and through, and now it's important that you didn't jail that anterior tibial takeoff. So now here's your balloon coming down. You're going to see that Vishal is going to take it past 30, right? And we're having trouble going again.
Yeah, maybe just balloon here.
We might have to laser from above. So we're
Can you
gonna
dilate?
No, no,
See
can-
whether-
Yeah, we're
Yeah.
done.
yep, we're going to dilate right now.
We'll push it
And
forward.
then we're going to try to push forward. The other thing to do is to get a triaxial system, and then go ahead and use the triaxial system to go ahead and give us more pushability. So he's going to walk back. I'll balloon the whole track, and then we'll try to go with some speed. But I think this is a good demonstration right here. This is a 2.0 balloon only that we're using.
Recently, we started doing radial access and
For-
kind of floss from the pedal to the radial and intervene whatever's necessary. The long balloons now, 170.
But explain to me, Romy, why? I mean, just because you can do it
400
doesn't mean we
pound
should do
patient,
it.
big belly. He's got previous extensive disease up there.
Biggest
And
issue is common femoral disease.
yeah,
Very often
that's
we're dealing
what I'm
with
talking
that. It
Yeah.
becomes an issue.
but you got to treat that as well. So that's the reason why. And I do all my
Right.
stuff on 90% of my OBL
I
Laser.
outpatient.
don't want
Laser it.
Just don't want to
All right, give me the
complicate it.
microcatheter.
Let's get a laser. We're going to get a laser now. We're going to have to push this wire forward.
That's okay. Laser will keep going, no?
This is too soft. You got to push it forward.
Hold on.
So we're
Hey,
going
so
to,
PK,
yep.
we're up against a little bit of time, but we
Yes,
can
yes,
come
yes.
back. Do you want us to come back after a talk?
Why don't
and
you
see
do
how
that
things go on?
while I set up the laser, and I'll go ahead and do a laser. Maybe we'll come back and show you our final picture. But I want to show you what we have now.
Okay.
So at least you can see what we have before we leave. So you can see that the flow in the posterior tibial is beautiful. We are in the dorsalis out of the anterior tibial, which we're going to laser and balloon, and hopefully we'll see it. If you can't come back to us, we'll send an image to George so he can show it to you later on. So
We'll definitely come back. We'll
Thank
definitely
you.
come back.
Thank
We'll
you.
see you in about 5 to 10 minutes. Okay.
great.
Okay,
Let's push this forward. Come on this side. Let's push this
So
forward. please.
while we're away, let's go ahead and press on with the next session.
I got you.
No. Wet it. Get a wet one for yourself.
Yeah.
Dr.
yeah.
Put a wet one in your hand.
Yes.
Because or else you shear the vessel. Just
All
hold it
right.
with the
So
wet
we'll
one. Just-
we'll go
yeah.
back after we do this
You got to feed
initial
it. Feed.
discussion on
Beautiful.
hypertension, current guidelines, which I know if you guys have been paying
Get the laser
attention,
ready,
there's a
please,
little bit of
somebody.
moving
That's good.
target. So,
That's good.
Good.
That's good. It's clamped.
Dr.
It's clamped.
Robinson will set
Okay,
us
let me
straight,
put the
I'm sure.
microcatheter down.
No, put a
You
laser.
want to do it over this? Fine. Let's do it over.
Thank you, thank you. So just to segue, this is from the nephrology perspective. The case you just saw illustrates why dialysis patients should be taking their phosphate binders. This is all medial calcification throughout the body. And I think you need only a couple of years of hyperphosphatemia to see what you get.
Okay, hold on. Yeah.
So I think we just gotta go to the beginning of everything. This is just your historical perspective where everything started. This is a picture of
Straighten
the
this out.
first measurement of blood pressure in 1733. Stephen Hales, a vicar
What's happening?
in Kent, in England,
I'll do it.
was able to measure
Can't
in
do
a
it.
most
We'll
accurate
take it
way
out
blood
on-
pressure in a
Karthik.
horse
Yeah, I
that
got it.
translates
You have
pretty
to-
closely to a blood pressure in humans. So
Okay.
this is just to
Okay.
humble us a little bit that this is nothing
second,
new.
one second.
Yeah, yeah, take
It's
it
going
out.
on into over 300 years that we learn how to measure blood pressure. So when we look
You have to
into
take it
the guidelines for hypertension, we see JNC helping us with
not
all
live.
of these and going from JNC 1 and 3,
Huh?
where you cannot find too much of
We're
the
not live.
guidelines, to up to JNC 4 to 6, where you have
consistent
5
blood
minutes. We gotta
pressures
just speed
going
up
now
here.
into systolics less than 140/90. And then we
80,
get
80, definitely.
into JNC7 in 2004, quite a while back, where we get this perspective that blood pressure
I know him really
systolic
well.
have
The
to
radiologist.
come
Okay.
less than
I don't have the
140
wire,
over
but we have a
90.
clamp, though. How does it matter? We have
A
clamp,
little
right?
bit of a
Yeah,
wacky
real guys?
definition of
Yeah,
hypertension. This pre
I know. Rail.
Oh, you don't have
There is no rail.
From there,
It'll come out.
several years, we
Nothing
get
will
into
happen. You'll get it.
JNC8, and we
It's on the
have
wire
here
anyways,
now the values
Yeah, I
Good.
have
I
it.
don't have the
change
wire.
quite a
Give me the
bit.
what one?
And from 140/90, we get a reprieve. And everybody felt pretty good about it, that now we get blood pressures of 150/90 or less than 140/90.
Yeah, well,
And I think it's very interesting.
I'm not.
The differential and the economics
You can
of
do it a
why
little bit
this
from
happened. When we see what happened with JNC up to JNC7, these were all the organizations that were involved in that. Over 1,500 people were participating in guidelines for this. So when we get to JNC8, none of that happened. The money dried out.
I know it's DSA.
So
I can't send
we
it.
have only at the most
Oh, Floro,
25 experts making these
no,
decisions. And
Floro.
JNC8
No,
with
no,
an evidence
no.
review from limited randomized controlled trials,
Leave it there.
participated from 66 to 2009. And I think
power
this
tension.
would cause the major
That's 80/80?
debacle into all issues
All right,
of
let's do
blood
this. Let's,
pressure because this
You
was
go, PK.
about
Just keep
1/4
power
You
tension.
give me a 1/0
Break
balloon.
it. Almost breaking it. Breaking it.
Sapphire.
Breaking it.
1/3.
1/0 sapphire.
all right, walk this out.
And
Okay,
so
give
this
me,
got,
I was thinking a
the
sapphire.
whole
yeah, but give me a
field
coronary
of
guide.
hypertension
6 French
very much
coronary guide,
upsetting
multi-purpose.
until the
Why?
landmark development of the
Why do
spring
you
trial.
get,
This is a
triaxial
randomized
system?
trial of intensive versus
Take a
standard blood
6 French
pressure
multi-purpose.
control.
6 French
And
multi-purpose
these are
is
the
funny.
nuts and bolts of Sprint, where we
Why don't we just take a
randomize
Caravelle,
patients
exchange it
to,
for a stiffer wire, and then do
standard
whatever?
control.
Yeah.
Oh,
What
try that one with the Zettel.
JNC8, we're telling you the
This one,
ideal
teleport. Let's see
systolic
if
blood
that
pressure
won't
is
go.
less than
Caravelle
140
won't,
versus
teleport
an
won't go,
intensive
Caravelle
arm
won't go,
where we
guys.
have systolic pressures of
Caravelle
less
is
than
smaller than
120.
I know, but
Imagine
Caravelle is
that.
we've
1/0.
done 1,000 kids
So
with this.
the inclusion
Caravelle.
criteria, pressures 130/80, and the primary endpoints were mostly all cardiovascular. But most important in Sprint is very important that you remember this when you analyze the different meta-analysis, the different studies on hypertension, excluded patients with
Wet one.
stroke,
Wet one, please.
patients with chronic renal disease, polycystic,
Mean what
many
pressure there, Karthik?
advanced chronic kidney
It's bleeding?
disease, proteinuria,
It's an ooze, but no hematoma,
patients
so
with
it's okay.
diabetes. These were non-diabetics. And I think the
Keep going.
results of Sprint were quite dramatic. The trial was stopped because you see the spread in
Nice
differential
rail, guys, both
and blood
sides.
pressure was very effective getting to the goals on blood pressure. And when we see at the Sprint primary outcome, the cumulative hazard was also
I think the
very quickly.
tip
This
is
why
damaged.
the
Okay,
study
walk
was
this out.
stopped.
Give me a Caravelle.
It was early because it was a huge
Give us a
difference
1/0
between
balloon
the
too.
standard and the intensive
Caravelle
arm
first.
of the
Not gonna
study.
work. Hopefully
And
it
we look
works.
at the
No,
mortality.
not yet.
no,
Actually, let's do
also
that. Let's
No,
do
no,
that.
such a dramatic difference
Open
in
Caravelle.
all groups.
Open Caravelle. No,
that
no,
I
PK.
think
Don't
Wait,
take
wait,
it
wait.
as a system.
cause,
Let's do this with the Caravelle,
significant
guys.
Fine.
revolution
Whatever
in
you
the
want.
treatment of hypertension. You look at the
It's okay.
adverse events
Fine.
between
Corset is
the
fine.
Corset is fine.
intensive and the standard area, we see that most of the intensive arm paradoxically had some adverse events, but you would have expected better blood pressure control in people that have more tendency for orthostasis and drop in blood pressure. We have more hypotension, more syncope,
Yeah, the
more
co-pilot is
fall,
open.
and
Don't
we
worry.
have surrogate
I did.
for electrolyte abnormality patients with hypokalemia that were treated
Really-
more.
really nice.
One
So
second,
that's the
one
flip
second,
side
one second.
of
Take
the
it.
She's
coin.
going to bleed like crazy.
1 second.
So
1 second.
going into what's going on after Sprint, I think this is a flavor where they tell you from NHANES by 2015, over the last decade or so, of what happens with hypertension. You
Rail
see here
I
in
need to see
green
design stent,
that
not
over
design
the
stent, the other
last several
stent.
years,
Yes,
the
I will
incidence
show
of
you.
hypertension
The,
defined
yeah,
by
super.
super mean
Don't go so low, PK.
still is about 30% of the population.
Super,
But
yeah.
until
That's good.
2009, 2010,
I follow
we
it.
have
Yeah.
patients with increased
stent now?
control
Okay, don't go solo.
Every
Don't go
time,
solo.
every decade or so, we have
now give me the balloon.
better control
Now give me the
until
balloon.
2010.
Give me my
So the
caramel.
law of the unintended
Try the
consequences
caramel.
we have
It goes.
here now
Try,
that in the last
We don't have time. Give me the balloon.
decade
open the balloon,
or
please.
so,
Keep going
we
5 things. I know
came
it's not
flat.
Sure,
The
sure.
upper line tells you that
Go
the
with the balloon.
relaxing the
20,
rules
20,
really
15, whatever
have
balloon you have.
had the unintended
You think it's a
effects of
support which is an issue?
worse
Yeah,
blood
definitely.
pressure control.
Yeah.
And just to bring up perspective here, this is an analysis of how is it that we better control blood pressure. This is from the California, from Kaiser Permanente, how they control blood pressure in different iterations from 2001 to 2009. And in the latest, in 2009, this is how they introduced the stepwise control blood pressure, starting with a thiazide diuretic, adding an ACE inhibitor, adding a pyridine calcium channel blocker, adding a beta blocker and spironolactone. And following this in a rigorous manner has gotten them a tremendous amount of effectiveness in blood pressure control. You see here from 2001 moving into 2009, patients that with blood pressure control went following this algorithm from 40% up to 80%. So if we all follow this easy iteration, I think we will have much better blood pressure control. So the American Heart Association in 2015 kind of redissected, looking at the results from SPRINT, blood pressure goals directed to specific condition, in this case, looking at coronary artery disease, acute coronary syndrome, heart failure, and peripheral vascular disease, what the class and the evidence for blood pressure control.
Try it now again.
And I think adding to that, in Annals of March 17, we get the distilled results from all these revolution following SPRINT. In terms of treating adults age 60, because JNCA telling you to relax your stance for people above age 60.
By the time you decide,
SPRINT show in an unequivocal way that treating patients even to systolic pressures of 120 to 130 was very effective, decreasing morbidity and mortality. So recommendations from this latest panel in 2017, patients above 60,
I'm telling you.
strong recommendation to treat for pressures above 150. And if you have history of stroke, TIS to lower less than 140. And this is just to give not meant to be read, but this is a flavor of the algorithm from JNCA that is still helpful in terms of how to add the different layers of drugs. So
should we go from below now?
That's the only thing.
Maybe guidelines telling us now that instead of pre-hypertension, we have this notion of elevated hypertension, blood pressure 120 to 129, and we have stage 1 and stage 2. So this is literally back to the future, because this is what JNC7 shows, the one that had the input of so many organizations and 1,500 specialists.
Okay,
so
give me a guideliner.
JNC7, and I think this is the latest on that. So in terms of hypertension guidelines, now we have an expert panel.
Get us a guideliner.
Change back to a lower number, and after SPRINT, I assure you there's not going to be any other trial like this, because
the
this
laser
was
will kill it too.
Incredibly
Get us
an idea.
Get us a guideliner.
Trial to
I have an idea.
and very expensive.
You want to take Phoenix?
And
just
so
go drill
I
it?
think you have to balance.
Get a Phoenix, guys. 5-inch Phoenix.
SPRINT, such as the diabetics and patients with significant
Get a 5-inch Phoenix device.
cardiovascular
It's the front end.
All right, let's move. Let's move. 5-inch Phoenix.
Get a guideliner.
Guidelines also will help us, I think, round this up. So moving on quickly into patients that don't, you cannot reach blood pressure control. And we have here,
we don't have 5-inch Phoenix.
Give me a 3-0 balloon, 3-0 100 balloon.
The numbers in different
Can you
countries
go get it?
of patients that are not uncontrolled. 61% in Japan. In the US, 53% of patients are not at goal. And we look at the forms of human
something.
Very much
anything 3-0, 300, 120.
Lion's share of the control of the etiologenesis of hypertension.
Yeah, guideliner.
So talking about non-pharmacological ways of controlling hypertension, you will hear a little bit about the denervation trials, but this is something that we here in St. Louis are very intimate. We have worked for many years, the vasoreceptor activity, I call it the thermostat, putting a match
real?
under the thermostat, pulling the baroreceptors into sending a fire signal that you harness your own activity against it. This is the Rios system, the first generation. And this is one just patient that
Get the
was
rotor ready
taking,
for
one patient in St. Louis was taking
Get the rotor ready.
35 medications, is down to one. Blood pressure is down from the
CSI.
200 to
Actually, no.
130.
Get the rotor
And
ready.
this is over 15 years
Rotor.
of the baroreceptor activation.
You have it?
And
Give it.
you see now that the new generation lead is very, very small, is unilateral, and this will see another day. So variations of the theme, you see that
Give me the coronary balloon now.
You don't want the trio?
given rise also to new innovation
Coronary balloon as well.
to kind of very
Coronary
creative technology.
dual
We
balloon.
have here an endovascular prosthesis
Okay,
that you
I don't
can
have it
put
yet, but keep going.
on the carotid, can change in the stoichiometry or the
Okay.
geometry of the vessel, and this has a give. So it's not a constant stimulation. It just moves with the beat, so it's stimulating the baroreceptor in an active fashion.
Show me above.
And this will have a point by changing
Okay, go up.
the shape of the vessel
Show me
constantly.
above.
I think
Where's the top of the
creates
balloon?
this stimuli
inside
in the
the-
baroreceptor.
Okay, go up now, go up.
Yeah.
The problem with this
Did it
is
cross
that,
peak here or
as
no?
you
No.
may
No,
know,
go up.
carotids
Up,
change
go.
a lot with the
Going up.
specific patient's anatomy, and too big and too small may be a problem. A lot of the carotid
6, 8, 10.
stenosis and
Down.
plaque will be an exclusion criteria for this. So
See
we go
this?
into the renal denervation studies. I'm not going to go in detail because the next speaker will talk about it.
Walk it
But
out now.
these by no means have stopped. I just
Now give me a
my
balloon.
part
2O
of
balloon.
this is that
2O balloon
we
first.
have
Can I go to
now
2O?
many,
Okay, you wanna
many
try this?
different
2O balloon
variations
first.
and flavors of the theme using
I think it's going to go.
frequency
I mean, we
ablation,
got the guideline
ultrasound,
almost there.
pharmacological blockade,
Okay.
and
2O
just
no, 2O, any 2O
unfortunately
balloon,
the
please.
first generation trial was a perfect storm where the failure
Sorry.
was
No problem.
to be shared by many partners, between operator, between design of the trial, between the kind of one that we were
If
using.
the laser
kind of
didn't go,
tool.
Phoenix will go.
So
Oh,
all
yes.
of
Go,
this is
it'll go.
speculation.
Let's do it.
when
That's
we
Because
go,
next.
Phoenix
and
is
I
the
think we
forward,
have
that's
learned
next.
a lot
Yes,
of
I
these
told him it's an
trials.
end hole
End hole.
There,
Anything with end hole, it will go.
this is something that we are entertaining also, those pharmacological blockade of sympathetic nerves.
Wow.
This is
Okay,
the
stay there,
ultrasound
stay there.
machine.
Stay there.
And I think the
It's okay,
problem
it's okay,
that we
what
need
happens?
to wrestle with denervation in the future
Push
is
Now
it,
see
that
if you
push it.
got
Now
unfortunately,
push your guideline up
even
again.
though
I'm sure he's doing that.
you may effectively
Now try it. Now
denervate,
pull the
they
balloon
may
back and
grow
go back
back.
in. And
And
see.
this
We
is
push the
something that
guideline,
we
hold on.
have to learn
Good.
to deal with.
Balloon in.
So there is a potential indication for denervation in the future.
Nope.
Okay, wait
Another
there,
thing
wait
coming
there.
down the pike is the notion
Now try
that
it.
neurohormone
Sideline is this one.
hypertension,
Mm-hmm.
sympathetic
the balloon down,
driven,
it's too
is
big
not
of a
the only
balloon.
form of hypertension. I think we know that as we get
Give me a
older,
short, smaller balloon.
sympathetic drive
Give me
declines.
a 1.5.
That area has to break.
1.5 balloon, 1.5 current.
Take the whole thing out. We'll put the Phoenix in.
Yep. Let's go
And
with
it
the
goes
Phoenix.
down with increase,
You still
with
need that,
loss
guys, or
of
no?
aortic elasticity.
All
right, where's the
vessel.
store
And
monitor?
if you're familiar with the
So
Let's clean this up
vessel
quickly before we go
function
live.
on the aorta,
I'm taking out the
same like,
guideliner.
firefighters, I think
clean this up.
loss of elasticity will increase your systolic pressures. And I think the notion of using diuretics or hypertension that has
I
worked
want
well
this
for
table
us,
clean.
you have to understand that you have to reduce effective blood volume closely to 25% of the circulating volume to really, really make a difference. So just by 1 liter. So diuretics also
clean
have
everything, I
a
guess.
counter clock effect when they activate the renal
Okay, 10
angiotensin
slides.
system. So if you have a system where
Sure.
you
10
can
slides,
shunt
speaker. And
blood
then they come back.
from the
No,
arterial
not yet.
to the venous
Keep going,
side
keep
that
going.
has high
Wow.
capacitance,
Keep going.
this is an example of
keep
what
going.
happens
No,
when
dude.
you
Show me
create a
above.
shunt. As
Yeah,
a
because-
nephrologist,
Feeling.
we put AV fistulas and we notice that patients
They're in a-
lower the blood pressure
He's still in the
almost
sheet.
immediately after the creation of the fistula. So this
No,
is a
see?
tremendous
Why is it not
innovation in the
working?
field, the Rox coupler
Why
device
is it not
Because
working?
that
it's
allows
kinking.
for a fixed shunting
It's
of
kinking in the
about
in the,
800 mLs
in the sheet.
per
The wire
minute
is
of
kinking in the
blood
sheet. You
to
have more
this
wire to push?
coupler from the
I have more
arterial
wire to
to the
push.
venous side, put on the
It's too stiff.
iliac
I guess.
vessels very easily,
Okay, push the
and
wire. Give me more wire
you
to push.
just see
Push the wire.
immediately at the placement
Push it
of
all the way
this
to the
drop
top.
of blood pressure that carries now over 2-3 years. This has been
Hold
done
on.
very
You want to go
effectively
live,
in
PK?
Europe, and
Go.
here in the
I'm going
States,
to
I
Not
think
yet.
it's been
Oh, yeah, we can go live.
Yeah.
You cleaned up,
the
Osman?
trial is ongoing. And this is a little bit to Star Wars stuff. This is the electroceutical coin, and it sounds a little far-fetched, but they're putting stimulation of the medial nerve, somehow stimulating for 30 minutes once a week, and something that is implanted under your wrist, stimulate all the vasodilator aspects.
When this bends, you want to pull.
Stimulate that.
Okay, when it bends, ready, watch the sheet. Watch this now.
So
see, pull it.
Very little invasive procedure
that
can have long-term events. So you see up to 4 to 6 weeks. You see here a drop on blood pressure in the early studies on that.
Pull the wire.
So, on summary, in this aspect of the top, persistent hypertension is still a rule-out that requires a lot of skill.
No. Okay, this is out. All right, give me a CSI. Give me a wire. Give me a new teleport. And give me a Viper wire. New teleport fast.
Another teleport catheter.
For many patients, this will be a very, very
good
solution.
Move at the speed of light, I'm telling you. Habib, new teleport. Teleport.
Oh,
shit.
Okay. Teleport.
So James, hold on a second, and we'll finish the live case. You back, PK?
Yeah, I'm here. I got to tell you, we've been struggling like crazy. So let me tell you everything we did. So Vishal, go scene minus ×2, please. So what we did was we externalized the wire, and then can someone go scene minus, guys?
Yeah, I'm going there.
So what we did once we did that, we went ahead and used a guide liner over a balloon to get the guide liner way down. Oh, before that we did the laser. We did the laser. Show the laser, please. So laser would not break that area right there. Then we said, fine, let's go put a guide liner in and get more support. So we used a 3.0 balloon, tracked the guide liner down, then did multiple balloons, including the coronary 1.0 balloon, which did not cross. So now what we're planning on doing is going with a CSI. I'm going to lose my wire position and change out for a CSI, and then see if that works. Obviously, we're pretty much very, very frustrated, but we've had cases like this a couple of times that where we were able to track this catheter, the support, or the support catheter all the way down, and then snake a CSI Viper wire down, and then do a CSI. That's what I think is going to end up happening here, George, as we come down. So it's not going any further than this. So I'm going to have to lose the wire. So I'm going to have Karthik pull the wire from the bottom without losing it, and I'm going to go with a CSI wire from the top. So what we're going to do, the key here is not to pull it out of the catheter completely. So what I'm going to do is relax the catheter, and Karthik is going to pull the wire slowly. I'm going to try to gently advance the catheter. It's not going. So at this stage, what Karthik is going to do is, as he pulls out the wire, he's going to keep the wire around 30, so he still has a track, and I have a target to aim for. Give me the Viper wire now, guys. Now what I'm going to do is go with the Viper wire from above and try to snake it through once it's out. So Karthik is still pulling from here. Obviously, it's a 300 long wire. We're not going to lose this wire. I'm welcome for any thoughts from the audience. I don't think, do you think a sheet from below would be the answer here to finish this case quickly? Or I have a feeling we're going to run into the same problem again there.
Yeah, I mean, it might be, because again, I think that you're not going to have to go with a tremendously large sheath, and I think you're running out of moves, but this one isn't. I mean, let's just see what happens.
Yeah, so I'm just waiting for Karthik. He's pulling it out. I'm just making a little curve on my CSI wire, and I'm going to go from above. As we all know, the Viper wire is not the best wire.
It's still up there.
And I think it's out now.
Because you cut the wire, right?
Yeah, that's why it is. Okay, it's right there.
So we cut the wire, so we couldn't see the tip.
Especially the back end.
Oh, you lost it? Oh, no, you still got it.
No, it's still there. I have it.
So we're going to try to go with the CSI wire.
It's right there.
Give me a torquer here, guys, on this.
Mm-hmm.
So we just hopefully, if this sneaks through, I think you need to put it on for me.
Oh, yes.
If this sneaks through, I think we'll be okay. I'm just praying. So one of the things that's worked, and it's sort of in the coronaries as well, as everyone knows, when you have these tough cases, sometimes only rota is going to work. Then if that's the case, that's the case. And I think we're okay here. Okay, let's do CSI. So let's get a CSI, guys. So
right,
yeah.
Okay. We may do another talk. Is that okay? And then come back and see.
That's fine, George. We're gonna definitely get through this. I have a good feeling now.
Okay.
That the CSI went through.
Right. Keep at it. We'll see you in a little bit.
Got it. Work it out, guys.
You want to try Phoenix?
CSI.
All right, so now it's my pleasure to bring up Jason Fontana with a topic that I think is still alive and well, although it's thought to have been dead, and that's the innovation. I'm really excited to hear this.
Thank you. Appreciate
Show me
it.
above, guys. Above, guys.
Somebody floor
Show me above.
You have the floor.
You have the floor, BK.
Talk about maybe not the death, but the reboot of renal denervation. So I'm excited to take you through the update of what the trial has been.
Almost
I think
done.
that
push
when
the
we,
wire down.
my
Okay,
slide
you're on.
there.
Michelle, I got it.
Of Medtronic.
Ready?
I think
I think you
also
lose the wire now, right? From above? Or from below? You want to
Agenda.
Yeah, I lost it.
Oh,
I pulled it out. As soon as you crossed, I pulled it out, BK.
Put it in the
Although
bowl.
I
Give me a bowl.
We give you honor.
Thank you. I appreciate that.
There, right here.
So I think
Here, guys.
it's been a pretty
Hook it.
storied path, renal denervation. I think we
Habib, you
technology
gotta be
triggered
fast. Fast.
Go.
sort of the peak and hypertension 2. We all remember hypertension 3, some of us more than others, and at ACC in 2014. We've gone on this comeback where we've seen spiral off, spiral on, and the radiant solo data. And now we're in this, what I would call the plateau of productivity, where we have 3 pivotal
Ready?
trials controlled going on in the United States as it relates to renal denervation.
What do we
This
gotta wait
point in
for?
time,
The flash.
and
Flash. 1 second.
it was very eloquently said by Dr. Rothstein. I will probably take this approach, the old Donald Rumsfeld quote. There were known knowns, there were known unknowns, and there were unknown unknowns at that point in time. There's a tremendous amount of work that was done to try to really understand some of the
Don't look it.
We heard about some of those, whether it was the procedure, whether it was the operator, whether it was the device, and or the patients that were studied. So a lot of work went into examine and look at all those different areas and then come forward with a series of trials to best try to really understand the performance of renal denervation. So
Whatever he did,
when
he's
you
not
look at before,
moving his foot that much.
for Simplicity 3, talked about performance goal for safety. We talked about efficacy with
we're ready?
office blood pressure.
Habib, ready?
Design was controlled with controlled medicine in the population with severe resistant. I think after
medicine?
Simplicity, there was a group that got
Hold on,
together,
go.
physicians, industry, as well as the FDA, to talk about safety, still performance goal, but
Good.
thinking about novel approaches and novel techniques.
to
Efficacy,
go?
really thinking about blood pressure. Design included a washout and make sure that it was still sham controlled and
No, no, just, yeah,
randomized.
keep it attached.
Population, more moderate risk patient population.
Any reason we're waiting or?
No,
And
he's priming the
we're
catheter. Hold on.
looking for and understanding predictors of
She's
effects and
suctioning.
response.
What size is
And
this?
so I think that really culminated, and as we talked about, there are a lot of different devices that are under
Yeah, see,
investigation
there
right
is
now.
one.
The
Sorry.
two I'm going to speak to in detail are the spiral
Where
catheters
did
as
Phoenix
well as
even go?
Paradise
I think you just didn't have enough
ultrasound
attention
catheter
on this.
from
I
think it looks
Recor.
good.
Just too
Those
heavy
I
to
would
make the
say
lab.
today had the most sham-controlled data. So I'm going to walk us through those trials here. I think when we talk about the trial designs for renal denervation studies and what's gone on to date, there's been studies in the absence of medication, understanding that this was the purest kind of experiment we could perform, really kind of reducing any confounders across the board. We did that. There's an
It's gonna
interesting
work, you know that.
component there from a
You
patient
got it.
We have the
enrollment
wire.
perspective.
Keep going.
Of that trial comes from self-referral versus
Yeah, then we
physician
lock it
referral.
later.
Somebody has to pick
Interest
that up.
there. Presence of med, I think this is
Yeah.
what we really want to understand in terms of
not going at all,
adoption
guys.
of this therapy
No,
is what
keep going.
happens in
Oh, there you go.
Let me walk. It's
And we
just keep
could
in.
collect
Hold on 1 second.
real
Go.
had in 2014 to better understand the safety and durability of
1
effect.
second.
And so just
Wire's
kind of
good.
walking through.
Oh, watch it, watch it, watch
I am. That's why I have to see.
Off-med trial. This was a sham-controlled trial. It was we would wash
There you go.
patients
Taste it.
off
Beautiful.
medications and
Start from here,
we,
guys.
washout period was
Whoever's good at it,
randomized
let's do it.
control, and there was
Cindy, guys?
3-month
Center.
we looked
So-
at
so-
the blood pressures to this
Yeah,
point.
center.
When we looked at renal denervation versus
I know,
the sham
exactly.
control of blood
Left to
pressure,
right.
there was a
One
reduction
plus?
No back,
Just
right?
go. No, but yeah, keep going forward.
from baseline. So again, this gave us a good solid component that we're back on track from an initial trial perspective. I think we also
I
wanted
don't understand.
additional data from other components in renal denervation and then continue to build on that.
Just stay right there.
Also, what was interesting that we started to see was
What are we
this
doing here?
always on
No, he's just trying to cross that lesion.
idea
Not
that
going, PK.
in the highest risk zone,
Okay,
in
let's
that early
increase the
morning,
speed.
we're getting a substantial
Go
reduction
forward a little bit.
in blood pressure versus drugs alone. So I think potentially
Stop,
this
stop
may
there.
give us almost a airbag-like quality to renal denervation versus a
There you go.
seatbelt type pump. So again, we've seen this now pretty consistently, and I'll show you again
Cindy, this please.
in our
Here,
trials,
center,
kind of
center.
similar. There's also been a great trial done by the folks at Recor, Radiant Hypertension
High
Solo.
pressure now? High speed?
In terms of terms
Take it
of
down.
that off-med patient design, similar in terms of a patient washout period, a little bit different in terms of the endpoint time
What
frame.
is
It was
this
at
freaking
2 months,
lesion here?
ambulatory daytime blood pressure. But again, set up very similar from an overall design perspective.
Wow.
And looking at the data here, it was
Pain.
powered
The Lord?
endpoint.
Okay, take a picture.
Blood
Cindy?
pressure.
Hold on.
Pressure
Jesus
at 2
Christ,
months.
what is
DSA?
this
And it
lesion?
did
1 second.
DSA?
Yeah.
significant
Cindy?
reduction versus the procedure. So again, in that off-med population, finding consistent data at that 2-month time frame. At ACC this year, they also presented their 6-month
Not bad.
results, which
Turn
I
off the
think
max,
is
Liz.
What is
lightning
this lesion
in
here?
this
Okay, ready?
field.
Again,
We
PK.
looked at
Laura?
Go closer, PK.
towards continuing to
Stop
add
that.
Ready.
medications,
So
and understanding the medication burden. I think they've done a
Don't go
nice
that
job
fast.
here from a prescription perspective, understanding that medication burden. And
that's all.
at 6 months, there was
There
a
it goes.
significant difference in terms of the number of medications,
Okay,
the dose
stop
of
now.
medications, and the load of those medications in favoring for renal denervation. at
There it
6
is.
months.
Cindy?
Now, even with that lower
Hold on,
burden of
no.
medication, the difference was
Go.
still maintained in terms of reduction of blood pressure at that 6-month time frame. Normalized for baseline blood pressure
All the way.
and medications, you see that that effect continues to grow. And so
Go
I
down to
think this is
32.
a
whatever that is.
first understanding
That's
of the
in it, right?
complications.
Yeah. Can you walk it out or you'll need to do more?
Do a few
Time.
more.
All right,
Do it
2
with
balloon
Very
then?
high pressure
putting
more. One
patients
second.
back on their medication from 2 to 6 months. We have a
Yeah,
similar
that's
structure in our off-med trial.
One run,
Despite
man.
that, still find is that folks don't exactly
Okay,
follow
good.
that
Okay.
structured approach to putting patients on medication. What we'll be bringing forward here in the next 6 months is urine and blood analysis on medication currently being run by a
Is this,
core lab.
can a balloon go on this, in this?
Why?
what's your why?
Hold on.
You have patients that they're
No,
going to be
it's unlocked,
witness when
yeah.
they take tell
Hold on.
patients that they're going to be blood tested and they're going to have their urine tested for their pills, and still you find
What's
that
going
they
on?
have
No, it's a
taken the
Dynaglide. Yeah.
circumstance. They've actually taken the wrong medication.
No,
So
just
it's a fascinating
close
area.
it and
I
walk
think
it
this
out.
is a step forward in that
Yeah,
space
no,
and
break
is
it.
going to be
But the wire's coming back. Hold on.
forward.
All right, just pull it
Shifting
out.
to on-med
wait.
and
Hold on.
One
we're
second.
in a
One
trial
second.
called Spiral
second.
on-med trial, which again, similar patient background,
Yeah.
but this time the
Yeah, so just
patients
do that.
were on diuretic, a calcium channel blocker, an ACE or an ARB and or a beta blocker, randomized to sham control. And then we followed these patients right now.
Hold
We
on.
followed them to 6 months and we'll continue
One
to follow
second.
them
All right,
accordingly.
what's happening?
No, I'm just trying to get
What
the
we saw
Dynaglide.
is that again, at that baseline, you have the same, no difference in medications and no difference in types
Hold
of
on.
medications.
We should be able to wire
And
it
again,
in.
across
Just don't worry about it.
the
Walk
blood
it out.
pressure, at 6-month time frame, we did see
One
significant
second.
reduction
If it comes
in
out,
blood
it comes
pressure.
out. Don't worry about it.
Innervation versus a
Give me a
sham
field of wire,
control.
please.
One second, Michelle.
If it comes out, it comes out. Walk it out.
Let me see if I can wire it on
This
this.
shows again that kind of
It's
understanding
stuck.
of that.
It's stuck for whatever reason. Pull it out.
Yeah, pull it out. It's stuck.
Concept of being always on. We do see that differentiation favoring
Stuck
renal
on
Give
the
me a
wire,
wire
PK.
introducer now. What happened to King?
So again,
No, no. He's stuck on the wire.
Yeah.
This concept of always on, we think is going to be valuable from a
Can I have a wire introducer?
Yeah.
as we progress
New wire
over time.
introducer,
We
please.
Introducer wire,
You
please.
want a catheter?
blood pressures, both
You want a
systolic and
catheter?
diastolic.
Give me a,
So we
give me,
saw
Can I get a
that.
2-0?
give me a balloon, please.
And we
Can I
look
get a
forward to bringing
2-0 NC?
No, 2530.
analysis.
2-5. I want a
So
2-5-3-0.
totality there over the past 18
PK, it's
months,
open.
we've seen
It's
sham-controlled randomized trials
Let's show
with
Flora.
renal denervation demonstrating
Flora
both
Karthik.
Above, please.
I'm flooring.
Yes.
Above,
All the way above.
effect
It's already in the
This is
SIP.
the CSI.
of blood
Yeah.
pressure reduction. So we're building that,
Oh.
that foundational work and moving back forward in the field of renal denervation. One of the other things we've continued to enroll,
nothing
even
Oh, that's the collateral.
2014, Global Simplicity Registry.
Yeah.
This is a registry that
Take a
started
catheter.
with our
Give a catheter, guys.
first
No.
catheter
Okay.
design, point ablation catheter that
It
was
doesn't have
utilized
enough bend,
I know.
PK. Put the
hypertension.
catheter and then put it.
Now continue to
Flora,
enroll
please.
and include our spiral catheter.
I have to take
which
this
is
out.
the most effective.
No.
This is on.
These patients have been
Flora, please.
followed out to 3 years, and the majority of the patients, over 2,000 of
there
these
you go.
patients, have been
Okay, I'll show it down.
flex catheter. But we're starting to build now out over 100 patients to that 3-year time frame from a
That's
registry
it. That's it.
perspective
Good. Well, give me the,
to make sure
There
that
you
we're
go.
taking
Take a
full
long balloon, no,
look at
PK.
that
Give me a
over
two-
time. We
2530. 2530. Nano cross. 2530. Nano cross.
that's what he
And-
gave you.
Yeah,
in
it's
a
fine.
registry format
Can
with
we
more
clean
of
this
a
up, please?
kind of all-comer patient population, that the consistency of effect is
I
there
got it.
over time
No, I got
from
it.
both
Don't
an
worry.
office and 24-hour ABPM perspective out to that 3-year time frame.
Oh my
And if we we look at these patients, we pull out the spiral patients, we have a similar effect over time. So I think what we're trying to build here is good, solid control trials, and then providing understanding.
What did I do?
क्या किया तूने?
Broader
ऐसा क्यों हो गया ये?
pushes the registry. I think what maybe shift gears a little bit as I kind of
Cute little boy.
towards the close. What's been fascinating as we've kind of gotten into this space is the concept of the patient.
There it is, balloon.
No, one second. PK.
Really wasn't.
That's it.
I think it's always.
It's not going to go. Let's balloon this first, and then we'll go up.
I was thinking about the second in which it was brought forward was a first preference study looking at what a patient has to do with renal denervation or versus taking another tablet. I think that unfortunately that plateau that we saw before has a lot of it's multifactorial. I think one of those factors is just the non-adherence of patients to their medication.
Picture.
Unfortunately, about 30%
normal.
Across the variety of trials. I think this is also something that's really hard to control when doing clinical trials in chronic disease space when you're trying to take a point in time. So one of the things that we're also working on here and really partnering with a physician, professional from Germany. He originally did this. He's a nephrologist in Germany, and he asked patients, suppose your blood pressure was too high, you'd be taking medication for a long time.
It stopped oozing.
Your doctor advised you to have additional treatment. What would you rather choose?
Down?
Even if you have all
shit.
the same medication.
Mount Sinai endovascular team demonstrated
would you
CSI.
add another
What
tablet,
the shit?
or would you try a different approach?
Let me try to go forward. Hold on.
One second.
About 70 patients would add that.
PK, let me pull back and then you can go.
That would choose some type of treatment to treat their blood pressure. So this really intrigued the FDA.
It'll go.
Back in December, they had a general issues panel in which Medtronic, Recor, ROX, and others were participating. And one of the big topics was really the involvement of the patient in the decision-making process. And so,
there's a corner to a balloon.
क्या कर रहा है तू?
Patient preference study, and really looking at what is the risk benefit for a patient.
You have to feed us food after this.
Having a procedure done versus
one second. Let me pull it back.
It's been done once before in the field of obesity management and similar dynamic. At what point does the benefit? I think this will provide us an additional interesting component.
Push like an animal.
That's good.
Stop. No.
Now go up. Yeah. Very good.
And so, in summary here,
go.
Don't you think?
Go up. They're going to go up.
Don't you think Vishal was on fire?
Pretty quick.
Vishal was on fire with the
But in summary, I think renal denervation may help fulfill.
All the way up.
Took me 5 years, my friend.
There are 3 new suspected
Vishal was on fire. Fire from top,
down,
from bottom,
down.
Fire from below.
All right, give some nitro.
Give me some nitro.
Heart rate 58. Some verapamil also, fine.
And I think we'll learn more.
Yeah, verapamil is fine.
What's the AS now?
Hypertension 3. We actually found the same effect within hypertension 3, despite
how much AS?
What's the AS?
We have controlled trials currently enrolling globally. Spiral off pivotal, which is
leave it as a loop. Leave it as a loop.
I'm just keeping a smaller.
That's fine. Just walk it out. You just have to walk it out.
Make sure he gets a dialysis after this.
In driving that evidence forward.
Leave it right here. Just walk it out, please.
I don't know. Ask him. Maybe give it up
here, no?
We ballooned this before.
No.
With the 3-0. Okay,
the ideal treatment patient populations.
You want to give verapamil instead? If the EF is 25 with an AS?
Fit into the care pathway.
There you go.
What's really interesting is you start to get into trying to understand responders
10,
and non-responders.
14, 16,
just started.
Down.
35.
Stop. All right, let's walk it out. Let's take a picture.
You want me to give verapamil from here?
No.
Obviously, that'll very much magnify that signal that we're currently seeing.
I will take it from above so we can show them when we'll be done.
Furthermore, we're working hard to better understand.
Walk it out, please.
Of efficacy. So more work to do in this space, but I think
the low mag and show me the whole thing to show.
Kind of like to say that the computer's open. We're waiting to put in our password. So we're there.
Ready?
We're on our way.
Shut her in now.
Appreciate the opportunity to present the data that's out there today. So thank you very much.
Okay.
Thanks, Jason. That was great. We are part of the spiral trial, so if anybody has patients, please feel free to refer to us because we need patients. So thank you very much.
How's it going, PK?
Good.
Well, you just we're showing you the picture here. So we got through. Let me show you what we did. So CSI was what worked for us. So what we were able to do was get down, and then we were able to put a CSI burr. What size? the 125 microburr down, and then Dr. Guja and Dr. Kapoor went ahead and did a wonderful job of doing the CSI. After which we went ahead and did a balloon. As you can see, it's a very, very tight lesion here, all the way down, and the patient is, had quite some pain with that balloon angioplasty. So we did balloon angioplasty here, and then prolonged balloon while you were gone, all the way down into this level. And now this was the picture after that. We're going to give a little verapamil. He has a little bit of moderate AS, so we're going to give a little bit of verapamil. But you can see that the dorsalis pedis, or the anterior tibia, is open all the way down now, and it's got good flow. We need to see the foot a little bit better, so we might just do a little bit of cleanup work. But I think overall, George, as you can see now, he has 3 vessel runoff to the foot, and hopefully we achieved what we wanted with that arch, which is what we were concerned about. So, señor, no mueva su pierna, por favor.
Yeah, well, thanks for the case. It's a great demonstration of the importance of angiosome-directed therapy.
No.
And struggle sometimes.
So we're going to take a DSA picture right now, George. So I just want to show you a final picture, and there's your AT coming down all the way down to the foot, and we're going to probably have to give some medicine in the foot to try to revive that arch. But clearly, we've got wonderful 3-vessel flow down into the foot at this stage, and then we'll take it from here. So on behalf of Dr. Guja, myself, Dr. Kapoor, Dr. Khalik, Liz, Habibi, and Fausto, we really, really thank all of you for giving us this opportunity. Hope this case was exemplary. Really enjoyed sending it to you and preparing it, and we'll see you soon. Thank you again.
All right, great job, PK. Thanks a lot.